Hello and welcome to Keeping Children Active from a Physical Therapy Standpoint. My name is Patricia Stott and I am located outside of the Denver metro area in Colorado. I also do telehealth. I am primarily a physical therapist, but have a background in a few different things as well, such as athletic training, hand therapy, functional medicine, herbalism. I treat patients of all ages with connective tissue disorders from a physical therapy or a health and wellness lens. Today, I'm going to speak a bit about what hypermobility spectrum disorders and Ehlers-Danlos syndromes look like in our pediatric population that might affect participation in activity. We're going to review briefly what's already been investigated and then discuss some recommendations for activity as well. So HSD and EDS, they can present both orthopedically and systemically within our pediatric population as well, just like as in our adults. Obviously, we expect some of these musculoskeletal issues like impaired quality of movement, pain, or injury to affect participation in a sport or activity. But systemic issues can also be present in children, and those can impact movement as well. From our common presentation markers that we see in children, I went ahead and I highlighted the items in red that are more likely to directly affect physical activity. Gastrointestinal issues, mast cell reactions, dysautonomia, anxiety, and specifically in children, we're seeing separation anxiety, social phobia, and fear of injury. And brain fog or impaired concentration can impact how a child is able to tolerate physical activity and participation in sports as well. The primary things that we think of for those with HSD and EDS that will impede participation in activities are pain, coordination, fatigue, and instability or an injury. There's quite a few things that can influence these primary factors though, and the more common comorbidities that we're seeing in our adult population, those can certainly exist in our children as well. Dysautonomia, specifically POTS, can also be present in children, and that's going to impact both school participation and recreational activity. There was a study performed in China on the general population between the ages of 7 and 18 years old that found almost 7% presented with POTS. So this is in the general population, and we know that those with connective tissue disorders are more susceptible to having this diagnosis. And we are seeing this at a younger age. Just as in adults, we might see this as a decreased ability to initiate activity, a post-exertional malaise with increased fatigue, exercise intolerance, cognitive difficulty, and also pain after activity as well might be present. Also, as with adults, these conditions can also be layered. So children with POTS in general, they're more likely to demonstrate chronic fatigue syndrome, sleep disorders, migraines, irritable bowel syndrome, or functional dyspepsia and EDS. Well, any of those alone can make exercise more challenging, but they're more commonly seen together. So we have these compounding conditions that can really start to affect movement. Abnormal mast cell activity can also be seen in children with HSD or EDS. MCAS reactions can limit activity for a number of different reasons, including symptomatic exercise intolerance, joint pain, nerve pain or nerve tension that limits mobility tolerance, exercise-induced asthma that's associated with mast cell activity, or even reactions to their own clothing or sweat, which is what we're seeing in this picture here, is a reaction to both the sun and sweat from just playing outside for about 30 minutes in this child. And, you know, just like we do with adults, these systemic issues should be addressed to improve the overall activity tolerance and also quality of life. So we really do have to look at the comorbidities even within children as well, even when we're considering movement. Now, there might be hesitation in participation in activities and sports because of risk of injury for this population. And increased risk of injury, it's really not clear in the research. In regard to acute injury with those that are hypermobile, there doesn't seem to be a link, except when looking specifically at ACL injuries of the knee. Poor motor control might be a risk factor for those with hypermobility, though. We do have individuals with HSD and EDS that feel accident prone. And there's not a clear link between hypermobility and the risk of acute injury. Well, there's also no significant research on the severity of injury when it does occur or on what the recovery looks like after the injury occurs. So some individuals could demonstrate complications and delay in healing from an injury, and that could cause them to feel more accident prone for that reason. It's important to also recognize that these delays or complications might be related to additional comorbidities that are going to affect the healing process, like MCAS. There has been some minimal research on the type of exercise program used with children with hypermobility. There doesn't seem to be a difference in improving pain when applying a general versus a joint-specific strengthening program. So either approach appears to work with children. So we don't necessarily have to restrict them to specific exercise. We can find something more entertaining and functional, like a sport or an activity for the individual if needed. One study did show that strengthening into the hypermobile ranges might improve self-esteem, but it might not affect other factors such as strength or prevention of injury. That's currently unknown. Orthotics can be helpful, even in children if needed. Somatosensory orthoses that include orthotics and compression garments can help regulate somatosensory input and improve postural stability. Activity and participation is so important for social growth in children. We know that poor health and chronic conditions can increase the rate of anxiety and depression in children. Chronic condition like POTS can lead to decreased school attendance, lack of social participation, underachievement, and increased medical visits. Encouraging this normalcy and what the individual can tolerate with participation in activities can improve quality of life and the symptoms of their condition too. If possible, it can be helpful to connect the children and the families with support groups locally or online to establish community support. And just like adults, children can have roadblocks to participation as well, and perhaps more as they do rely on their family for transportation to these things. So we're relying on another person to get us to and from activities. Pain can obviously be a barrier to exercise, and this can be quite layered, even in children, as to what's contributing to the pain for the individual. So again, pain is multifactorial, could be coming from a number of different places. Dysautonomia and fatigue can limit tolerance to activities, even in our children. Again, we're seeing it at earlier ages. The child might not like the prescribed exercises. It might be too monotonous or it's boring, and they might not maintain the interest in an activity. Fear of movement and activity is going to impede participation. Impaired balance, proprioception, and coordination will change the quality of movement, and that individual might find it more difficult to participate in certain activities with that. Depression can impact our children as well and influence initiation activities or continued participation. Deconditioning can come from a number of different sources, so fear of activity, health flare-ups, pain, many different sources can lead to deconditioning over time. This can be really difficult to work through safely to return to an activity for someone dealing with these layered conditions. Anxiety around social environments is not uncommon, and it can be exacerbated by dysautonomia as well. So that is something that we can see, especially in our children. Lack of parental involvement is absolutely not to point fingers, but more so to recognize the busy lives in a modern day family, especially when dealing with a chronic illness as well. This can be much more complicated if one of the parents also has the condition that they're dealing with at the same time. Making room for movement and exercise can be really tough to plan into a family schedule with work and other responsibilities as well. Other medical issues can take up time in the schedule that might have been set aside for movement and activity. Lacking structure during the day to fit in the activity for children might be a barrier for some families. And then not understanding why movement is important, how much benefit it can provide if done safely can block individuals from participating. So let's review some of the recommendations for dealing with those roadblocks as they come up. So for those with pain, even a child, we can offer pain education and management strategies. Pain is, again, multifactorial, so the treatment is going to be individualized, but pain education can be pursued with a therapist. When dysautonomia or fatigue is present, that needs to be addressed before beginning an activity or an exercise program. We want to make sure that they can carry this on long term and they do it in a healthy fashion. So this really requires knowing the tolerated starting point of the individual and then understanding their own safe rate of progression that might have to be monitored very closely for flare-ups and ups and downs that the individual might have. If the child doesn't like the current activity or the past ones, it's really important to find what they do enjoy and we keep up without reservation, and how can we safely incorporate those things into activity or play. Fear of movement or participation is going to require a slow buildup in trust in their own body and their own reactions. Slow and intentional progression in an activity is going to be so helpful. Guidance from a practitioner can also be helpful in this as well. And then pain education and management can help reduce the fear with the activity going into it. If the balance is impaired, if we have impaired proprioception or coordination is noticed, finding an activity with intentional focus on those needs can be very helpful in improving impairments, but also confidence in the movement as well. Compression garments might also help with some proprioceptive feedback if we need some additional interventions. And then when dealing with depression limiting activity, focusing on positive outcomes can be helpful. Finding support groups for the child and or the family can also be helpful. Some mental health providers also specialize in movement therapy, and they might be able to create an integrative program for the individual. And we want to make sure that if we are seeing depression that's affecting an individual's participation and activity and social engagement, that we want to make sure that we do have somebody from behavioral or mental health on the team helping out the individual and integrating that into the exercise plan or the activity plan. Deconditioning is going to need a very focused and closely monitored gradual exercise program. Preferably monitored by a provider to accommodate for any flare-ups that might occur. Again, this needs to come with somebody that is able to shift very quickly and offer accommodations and a different route that might be less strenuous and stressful to the individual, but you're still getting the goals in within that time frame. With anxiety around the event or the activity itself, it could be helpful to directly work on the anxiety, but we can also recommend social support in those activity situations. So is there a sibling, a friend, or a family member that can join that individual for that activity time? And parent education as to why the activity and movement is important can be helpful to both engage the family, but also start a conversation with the family on how to fit these things into a busy schedule. Sometimes it can be adapting already planned family routines, or it might be figuring out how to shift schedules a bit. Conversation and communication with the provider is super important to figure out how to get this all in healthily. When there's an overwhelming amount of tasks and appointments for a child or a family with chronic illness to get through, it's really important to recognize that when to healthily put aside the physical therapy or the activity or the sport until there's more space and tolerance for it. I would recommend check-ins with the therapist, however, during those breaks or goals set or a home program given during that time. Okay, so what are the recommendations with sports for someone who is hypermobile? Well, the most important takeaway is that any activity or exercise recommendation has to be based on the individual and not the diagnosis. There's such a wide spectrum of this presentation in this condition that we can't make generalizations about certain activities. We certainly want to encourage healthy movement for the individual that they can carry on long term and be at the ready to find new activities if and when needed. I would highly recommend considering a sport-specific evaluation for an individual with a certain activity or sport in mind. The practitioner can then investigate the joints and the body parts that might be stressed by that activity to see if the individual is ready for that activity, or might be able to prepare a bit more safely with some strengthening or stability work. So pre-work before going into a sport or activity to make it safer. Depending on the individual and how they process pain signals, they might need to be taught to do self-check-ins with how their body is feeling to be sure that they aren't overdoing it or developing issues in problematic joints. In general, high impact are what we consider the higher risk catastrophic sports. So the sports that can produce more significant injuries, they might not be tolerated by those with HST EDS. This is really completely based on the individual and should be discussed with a medical professional. Safety first should always be the goal, but there are some individuals with HST and EDS that, based on their individual presentation, they can participate in activities that we might commonly think are inappropriate for those with a connective tissue disorder. So again, this is very individualized and should be thoroughly discussed with a specialized medical professional. I'm going to offer some general strategies for children and movement, and then we're going to review specific types of movement or activities in just a moment. The type of movement encouraged for this population, based on the issues that we typically run into, they really would be activities focusing on proprioception and body control or intentional movement. If we can, we'd like to try to engage activity at a younger age to teach joint position, avoiding collapsing into the joint with hyperextension if possible. For those that have hand dexterity and control issues, we can encourage play at younger ages with the hands or some weight-bearing activities to build up the arches in the hand as well. With any age group, we want to avoid activities that are aggravating to the individual that we can't support through any of our rehabilitative work. Some aggravation might be from things that we can support through strengthening and stabilization and modification, but if we can't find that balance for the individual, the activity should be paused until we can. Physical exercise in general is encouraged in those, not with just with EDS to keep up the strengthening throughout a lifetime and help stabilize those joints, but those with POTS or dysautonomia as well, and that encourages muscle pumping action and improves overall autonomic tone. So very important to keep moving in a safe manner. Play or activities that incorporate core strengthening and coordination can be very, very helpful for stability for the individual. With activity, compression clothing can provide some proprioceptive feedback for some and improve postural sway. Orthotics can be helpful if needed, and also appropriate bracing if needed can be reviewed with a therapist to figure out the type and wearing schedule. So intentional movement or mind-body sports can be helpful with body awareness and planned movement for those that need to work on their coordination and proprioception and stability. Those sports that are more intentional for the individual are those that the participant doesn't really have to worry about the actions of another person or object, so we have less contact and more control in these sports. This is a list that looks at participation and not necessarily the level of competition that might come with increased risk for injury. So again, the most important takeaway is that it's going to be based on the individual and what they can safely and healthily participate in. When we talk about these mind-body connection sports, there are quite a few of them. And again, it depends on participation and the type within the category that we go into. But martial arts is a very mind-body sport, very intentional movement. And this is with the thought first of removing the sparring or the contact from it. But our martial arts, if done without the contact, could potentially be a safer activity for some of our participants. And we do have gentler martial arts like Tai Chi and Qigong as well. Dance is also something that has a lot of mind-body awareness to it, as does yoga. Ninja classes and parkour, a little bit more movement involved, but there are plenty of children who do very much enjoy these classes and might be able to safely take them. Swimming, cross country or track and field, so running and field events. Rowing, rock climbing, weightlifting, cycling, fencing, diving, figure skating, and gymnastics as well. And again, with gymnastics, that's one that we tend to think of as an unsafe activity for some, but we have to consider the individual and the level that they're participating in. So this is very individualized. And to finish up, I'm not going to go into too much detail on this slide, but it's really important to understand energy expenditure, especially for our children. Staying active in a safe manner is highly recommended for those with HEDS and dysautonomia. Finding the support where we're available throughout the day can be very, very helpful. And for children that are school age, having accommodations in place to allow that energy conservation can be very, very helpful. So the links are provided here for each of the diagnoses to the recommendations of the accommodations to consider. So highly recommended for children that might be struggling with energy expenditure to consider these accommodations within school for those diagnoses. And just a few slides of references from everything that we've gone through. And to wrap everything up, so children with HSD and EDS, they might carry some of those qualities that make participation in activity more difficult than with the general population. So these children might be impacted by additional comorbidities that can influence activity tolerance. Activity participation is based on an individual basis of what the child is interested in and what their body might be capable of. So this might take a very specialized investigation to see if this is safe for an individual. And finding a consistent or even a rotating activity that incorporates balance, body control, and strengthening to keep up long term is highly recommended. And also finding team members that might be able to help assist with some roadblocks that might come up over time. Highly recommended to find the team that can really help provide a really safe long-term strategy. So I just want to thank everybody for listening in. I really deeply appreciate all the practitioners, patients, and family members for participating in this event and looking to learn more. So thank you so much.